सर सुरू करा सर.
Okay, Sachin, thank you.
Yes sir, please start sir.
Yes. My dear, yesterday we discussed about the Nirukti, Samanya Hetu, Saman Samprapti, and Saman Lakshan. Now today really I wish to talk about the physical examination in cardiology. Very vast subject, but it is needed for the students. Few points are very common while examining the patient. Inspection, palpation, percussion, auscultation, and various tests for the elaboration of signs. Before going to discussion on the sign in cardiovascular diseases, I like to describe few symptoms which are very common in cardiovascular diseases. First, dyspnea. History of dyspnea is very important. Very careful history taking is important. The onset of the dyspnea, aggravating factors and relieving factors. History is important to confirm the level of the exercise. Whether the patient can walk on the plain ground at the same pace. It can walk for the distance, At which distance patient feels discomfort, breathlessness, and stop the walking. That should be noted. Whether patient can climb up or down should be noted. The level of the climb up, first floor or second floor, at which stage patient stop the walk, climb up. Whether patient can do his or her routine work. Can patient go to the toilet without any discomfort or with discomfort? Whether patient have the dyspnea on sitting without any activity. These 4 stages of the dyspnea must be noted, my dear. Grade 4 is moribund condition. It indicates severity. Grade 3 is also severe condition. Grade 1 mild and grade 2 moderate. Dyspnea and exertion is very common in cardiorespiratory diseases, especially in left heart failure, COPD and asthma, pneumothorax, pneumonia, pericardial effusion. These are certain common causes, angina and MI. Yesterday I told you about the angina equivalent. The dyspnea occurs, there is no chest pain in such patient. Patient of the angina sometimes comes with the dyspnea only, not the chest pain. Dyspnea, if occur in lying down position and relieved on the sitting, is known as orthopnea. Orthopnea indicates the pulmonary edema. Whenever the pulmonary edema, very commonly in mitral stenosis, the patient feels the orthopnea. And then paroxysmal nocturnal dyspnea, PND. PND occurs after 4 hours of the sleeping on every consecutive night. Due to decreased later respiratory compliance. Dyspnea, orthopnea, and PND are the cardinal features of the left heart failure. Cough. Dry cough and later productive cough. Pink color sputum, frothy sputum, very common. Pink and frothy color sputum is very common in mitral stenosis. Pink coloration indicates the presence of RBC in sputum. Chest pain, very common. Feature of the cardiovascular diseases, very common is ischemic heart disease, MI, pericarditis, metrovaricose metal, aortic stenosis, obstructive cardiomyopathies, etc. Dyspnea and exertion is very common in angina. Dyspnea and arrest is very common in unstable angina. Severe chest pain is very common in MI. Sometimes there is no chest pain in ischemic heart disease. The pain occurs only in the remote area, referred pain, the neck, jaw, shoulder, hand, sometimes ulnar side of the hand. Commonly left side, but sometimes also the right side. Sometimes patient does not feel the pain, only the numbness and tingling in hand. You may be confused with the spondylosis. After exclusion of spondylosis, if you do the ECG, you find the changes. Such features are very tough for the diagnosis. I remember when my senior friend MBBS MS came to me with the pain in the chain. He was senior that time, 1998. After going through the questions, I find, and when I auscultate, I found the fine grades at the base of the lung, and I did the ECG. My dear, there was a segment elevation. It was case of MI. There was nothing wrong. There was no chest pain, only the pain in chin. But a sophisticated clinical observation and ECG indicated the presence of ST segment elevated myocardial infarction. We shifted my dear friend to the hospital. There were 3 vessel coronary artery disease. Therefore, I requesting to the young generation to make the expert understanding of the clinical features. Chest pain also occurs in the pericarditis, but this chest pain occurs in the left of the chest, left pericardium. Patient feels the pain in the lying down, but after sitting a little lean forward, patient feels better. The presence of pulsus paradoxus and something other help you. I will talk later. The anginal chest pain is in aortic stenosis. Very severe chest pain occurs in the esophageal spasm. Very severe. Very close to the MI. Nitrate relieve the pain. Again a confusion. But ECG is normal. Nitrate is vasodilator. It is smooth muscle relaxant. So it relieves the pain in the esophageal spasm. The chest pain is important to rule out whether cardiac origin or non-cardiac origin. The pain is referred in the cholecystitis, peptic ulcer towards the chest. In producing pneumonia also there may be doubt. So all these must need to differentiate before going to confirmation of MI. MI must be confirmed whenever there is chest pain. Syncope is another feature in the cardiovascular disease. Cardiac syncope, very common due to arrhythmia, due to left ventricular outlet obstruction, as in aortic stenosis and obstructive cardiomyopathy, MI. Systolic dysfunction is very common cause of the syncope. Arrhythmia is very common. Carotid stenosis is also one cause of the giddiness. Anemia is also one cause of giddiness. Anemia also may be associated with the rheumatic heart disease. Sometimes coexistent diseases must be confirmed. Cold extremities, cyanosis, jaundice, pallor, indigestion, edema, or other features, oliguria. Decreased urine output occurs in both left and right heart failure. The reason is different. In left heart failure, because of decreased cardiac output, because of decreased renal hypoperfusion, and in right heart failure, because of venous stasis, because of venous congestion. In right heart failure, if edema is present, then there is raised JVP. Jugular venous pulsation is increased. Hepatomegaly is there. Raised JVP, congestive hepatomegaly with edema are the cardinal features of right heart failure. Triad of right heart failure. Dyspnea, orthopnea, paraximal nocturnal dyspnea are triad of the left heart failure. So you have to understand the common features and certain remote features like indigestion. Liver cirrhosis is very common due to heart failure. That also should be ruled out later. Ascites because of pulmonary portal hypertension in right heart failure. There may be pleural effusion due to congestive heart failure and also in presence of the ascites. Bilateral pleural effusion, but right-sided pleural effusion is very common in heart failure. These are certain things should be noted before going to physical examination. In physical examination, generalized condition is to be noted. First, the general status of the health, whether the patient looks sick or healthy, undernutrited, malnutrited, edematous, failure, pathetic, depressed, anxious, what should be noted. All these have the significance. In case of MI, patient is so restless, lost the hope of the life. It looks on the face. Severity always look on the face. You can see that. In general condition, you have to show the complexion, the color, discoloration. I told you yesterday. First cyanosis, two types, central and peripheral cyanosis. Central cyanosis present on the tip of the tongue. Very common in congenital heart disease, right to left shunt. For example, tetralogy of Fallot. Peripheral cyanosis is not present on the tongue, only on the periphery in heart failure. After rubbing the hand, if cyanosis decrease, indicate peripheral cyanosis. On exercise, if cyanosis increased, indicate central cyanosis. Such things should be done for the confirmation. Pallor is present or not, as in anemia, also in the rheumatic heart disease due to hemolysis. If jaundice, may be due to congestive hepatomegaly and as in right heart failure. Fever, high temperature, as in infective endocarditis or rheumatic fever, should be noted. Clubbing of fingers are very common features in congenital heart disease. What is clubbing of fingers? Hypoplasia of distal phalanxes. Due to hypoxia, the distal phalanx becomes hypoplasic. And so there is arbitration of the nail bed and window sign is present. This is a very important sign. You can see this happens like this. Note the window sign. Clubbing of fingers is very common in congenital heart disease. Cyanotic. Other causes are present: bronchiectasis, liver cirrhosis, Crohn's disease, chronic smokers, and sometimes as a congenital anomaly. Splinter hemorrhage, hemorrhagic patch beneath nail, in endocarditis. Postular nodes is small painful nodes on the finger tip in infected endocarditis. Purpurigresses in thrombocytopenia. Erythema marginatum, spelled in the palm erythema in rheumatic fever. You know the St. John's criteria for the rheumatic fever: carditis, arthritis, chorea, erythema marginatum, arthritis are the major criteria. The subcutaneous nodules should be noted. The subcutaneous nodule in the rheumatic fever is small, soft, movable. If it is larger, fixed, form, consistency is hard, on the blunt extensor site of the joint, please confirm the rheumatoid arthritis. Even in the gout, the nodules are present. There are too many conditions where the nodules are present, should be ruled out. But in rheumatic fever, the nodules are small, less than 5 millimeter. Should be noted. Xanthelasma and xanthoma. A fatty streak deposition around the eyelid, on the upper eyelid, is the indicator of the hyperlipidemia. Xanthelasma is again the fat deposition on the extensor site of the joint in hyperlipidemia. The family history is very important in hyperlipidemia because some hyperlipidemia is familial in nature, should be ruled out. In India, our life pattern, we are a good eater, we eat everything, whatever we like, we eat. And that again a cause of the hyperlipidemia. Indians are very vulnerable. We are very vulnerable. I'm telling you one thing here out of just box, but please note, the South Asian abdominal belly is dangerous. In this abdominal belly, my dear, the adipocytes secrete resistine, which develop the insulin resistance. Why Indian, Pakistani people, Bangladeshi, Sri Lankan are prone to diabetes? The reason is our belly. Take note. Encourage your people to reduce the weight, especially abdominal girth. For the other country, 85 centimeter, so for the India, less than 80 centimeter in male. For the other country, if 80 centimeter for the female, in the India, 75 centimeter. If 25 BMI is good for the American, for the Indian, 22 BMI. So please always read the epidemic in the India, not in the America, not the Europe. Our inheritance is very different than the American and the European inheritance. Their diet pattern, their genetic map, and our genetic map, our lifestyles in centuries are very different. We have to study our own people. This is the reason why I am talking about the cardiology in Ayurveda. We have to discuss that. So xanthoma, xanthelasma for the hyperlipidemic condition. Then edema, you are seeing the edema, confirm whether bilateral, pitting or non-pitting, whether present with the pedal part, whether it is dependent, ambulant. Dependent, ambulant edema is commonly present in heart failure, congestive heart failure. When the edema starts in the pedal part, it is localized only, then confirm whether patient taking nifedipine like drug or not. If patient hypertensive on nifedipine, calcium channel blockers, and develop the mild edema in the ankle part, please note it and withdraw the drug. Because these drugs can increase the capillary permeability and can cause pedal edema. So drug history is also important for the confirmation of the cause of the edema. You know, the nephrotic causes, hepatic causes, hypoproteinemia, venous insufficiency are the common causes of the edema. Non-pitting edema in filariasis, in lymph obstruction, in inflammation. So dependent edema, ambulant edema in heart failure. These are general conditions to look. Now we come one by one. Now we start to see the jugular vein. Right jugular vein is good to see. We are close to the right artery. Normally there is no pulsation in the internal jugular vein. Now you have to tilt the patient at the 60 degree on the chest and then examine the jugular vein, internal jugular vein. If it is raised, if there is pulsation, confirm it is raised jugular venous pulsation. When the pressure in right artery increase more than 5, it will reflect as a pulsation in the jugular vein. Jugular venous pulsation is very common in right heart failure, but also in pericarditis and other conditions. Now you see the ascites present or not. You see the dilated artery, that is telangiectasia. It may be congenital. Dilated vessels, veins are present over the abdomen in ascites. Varicosity should be noted. A few points on the inspection. On inspection also you can see the nobbing of the head. If a patient comes to you and always move the head, please confirm. And meanwhile you see the carotid artery. If the carotid artery is visible with the nobbing of the head, please confirm the aortic regurgitation. See the simple. Head nobbing, visible carotid pulsation. Later I will talk about the collapsing pulse, diastolic murmur, a confirmation of aortic regurgitation. How you can make the easy for the diagnosis is the matter for you. Think every time the very simple but sophisticated way of the diagnosis. Physical examination is important. Just you press it, the nail bed, and you feel here the pulsation, again an indication of the aortic regurgitation. Now after inspection, please come on the palpation. First part, the radial pulsation. Rate, rhythm, character, and volume. Ideally for the cardiologist, radial, brachial, carotid, femoral, popliteal, pedidorsalis, and anterior tibial. Bilateral should be palpated. Not only radial, every peripheral pulsation should be noted. Why? Yes, for the basic peripheral vascular diseases to understand. Okay, now you are on the radial artery to palpate for the rate. Don't go for the 15-second, 30-second pulse examination, at 2 minutes, 3 minutes. Note the rate, count the rate. Normal in between 60 to 90. Less than 60 bradycardia, more than 100 tachycardia. So confirm it first. And then rhythm, regular, sinus rhythm. Irregular. Less than 60 irregular, bradyarrhythmia. More than 100 irregular, tachyarrhythmia. Now irregular, regularly irregular, irregular. Very important. And in atrial fibrillation, irregularly irregular. As in arterial flutter, regularly, irregular. Another thing, missed pulse. If the pulse is missed, again note at which interval. At regular interval, again irregular. Missed pulse means premature ventricular complexes. When you find the missed pulse, auscultate that time on the heart and you find the sound. When heart sound is present, but there is no pulsation, confirm the premature ventricular complexes. My dear, very simple way. There is bigeminy, trigeminy, couplet, multifocal, all are there. All these should be noted only simply by the pulse examination. You will be surprised. 400 BC, one Chinese traditional medicine expert examined first time this note. And he found if this missed pulse is frequent, a cause of mortality. Observation based science, whether it's Chinese medicine or Indian medicine or Brazil medicine, allopathic medicine, all are having its own heritage with the hard working by the ancestors, and then science is developed with mature knowledge. Come forward. Rhythm, now character. You have to note the discrotic notch on the pulsation. Give the time. You are strained. You are in the hostel. Every day you make the habit to examine the pulse of your friend, to note that discrotic notch. Not so easy. Give the time. There is pulsar alternance. Alternate pulse is strong and weak. Alternate pulse is strong and weak. Pulsar alternates very common in heart failure, but very common in mitral stenosis. Slow rising pulse in aortic stenosis, collapsing pulse in aortic regurgitation, pulses by experience in combined aortic stenosis and regurgitation. Note the pulse is either strong or weak. Strong pulsation is very common in like very hyperkinetic syndrome, fever. Weak pulse in the dehydration, in presence of the heart failure, in presence of peripheral vascular disease, in atherosclerosis, like condition. If pulse is absent, confirm the peripheral vascular disease, especially Raynaud's disease, and then the volume. In dehydration, volume is reduced. In very like condition, the volume is increased. So note the volume. The rate, rhythm, character, and volume, these four should be noted. For the character, ideally is to note on the carotid artery. When you are palpating the carotid artery, don't palpate both carotid artery at a time. You are palpating the both carotid artery at a time, my dear, you can compress the carotid artery and blood will go to the less to the brain, will lead to the giddiness. Take care. Certain precautions are always important. Now you are examining the radial, brachial and all. Okay, it is noted. Now come on the blood pressure. Note the blood pressure. Before noting the blood pressure, your patient must be quiet, relaxed. Either in sleeping or sitting position, very relaxed. Give the time. Because patient, if the angios, the sympathetic overactivity may increase the blood pressure. Take note it. Patient comes in the hurry and you start to see the blood pressure, there will be a little bit high blood pressure, may confuse you. But take the time. relax your patient. And note the blood pressure in both conditions. Ideally 3, but at least in 2 conditions, sleeping and sitting. One thing note. Normally the blood pressure may be a little bit less in sitting than supine, but less than 10 millimeter of mercury. If it is more than 20 millimeter of mercury, it indicates postural hypotension. Note it. This is important. And this postural hypotension may cause of the syncope, may cause of the dizziness. Patient may come that, sir, I feel the giddy whenever I in a standing position. But when I sit, I feel the good. What is the reason? The reason is less perfusion, and the standing means there may be orthostatic hypotension. This is the reason why to note the blood pressure on both condition, supine and sitting. When you are examining the blood pressure, you find the change of the systolic blood pressure during inspiration. If it falls more than 20 millimeter of mercury during inspiration, is confirmed pulsus paradoxus, a condition present in cardiac tamponade, in pericardial effusion, in COPD. This pulsus paradoxus only to confirm if you are very aware about the change in the blood pressure during inspiration and expiration. I'm telling you, measuring the blood pressure is not so easy. Be very careful. Cuff must be well tight, at least 2 fingers above the cubital fossa, assure the side, relax it, and then first the pulsation method and then auscultation method, note the blood pressure. For the student, it is mandatory. They should not be in a hurry. They must consume the time. After examining the blood pressure, now note the respiration, the same rate, rhythm, character. Cheyne-Stokes breathing is very common in heart failure. What is Cheyne-Stokes breathing? Ataxic breathing in medullary dysfunction. What is ataxic breathing? Kussmaul's breathing in metabolic acidosis. What is Kussmaul's breathing? All should be known by you. Rapid, deep breathing, that is Kussmaul's breathing in diabetic ketoacidosis. Asymmetrical breathing in pleural effusion, in lateral pleural effusion, in lateral pneumonia. Fixed breathing, less movement in COPD, in bilateral pleural effusion, etc. Alternate hyperventilation apnea is Cheyne-Stokes breathing. Irregular hyperventilation apnea is ataxic breathing. So after respiration rate, rhythm also should be noted. You know the respiration should be around 18 per minute, 1:4 ratio to the lungs respiration and heart rate. Note 3 points: pupil, blood pressure, and respiration. If you are talking about the brain stimulation, be careful there. That's not the point to talk today, but you must note this point 3: respiration, blood pressure, and pupil. Now you palpate the certain part. Again, the carotid pulsation, palpate. That is already you have done. If there is ascites, palpate over the abdomen, palpate for the hepatomegaly, splenomegaly, palpate, and then do the fluid thrill. All this. Now palpate over the chest and also over the heart. This is very important. To palpate on the pericardium. To note the palpable heartbeat. If beat is palpable, it is known as thrill. Normally, you find the thrill is not present. If it is present, it is known as, it is basically palpable murmur. And this thrill indicates the cardiac diseases, especially the valvular diseases. For example, systolic thrills in aortic stenosis and diastolic thrill in the aortic regurgitation. One point always note, if you come for the heart examination, the inspection is also very important. Note the visible heart pulsation. At which area it is visible? You know the four valve area, aortic valve, pulmonary valve, tricuspid valve, and mitral valve. Second, intercostal space, right to sternum, aortic valve area. Second, intercostal space, left to sternum is the pulmonary valve area. Fourth intercostal space, left to sternum is tricuspid valve area. Fifth intercostal space at mid-calcular line on the left side is mitral valve area. If the pulsation is visible here, confirm the corresponding valvular disease, the valvular changes. My dear, in congenital heart disease, you can find sometimes the asymmetrical chest in the children, especially in presence of ventricular septal defect, arterial septal defect. Now, because of earlier surgery, such things you can't see. But in our study in the UG life, we observe too many patients. And to be frank, we examine on that ground and we have confirmed that as it is congenital heart disease. So palpation, and then come for the percussion. Now concentrate on the heart area. You note the small, little bit dullness over the pericardium. If dullness is increased, it means there is pericardial effusion. Increased dullness, pulsus paradoxus, small sign means elevated jugular vein pulsation during inspiration. You are going very close to the pericardial effusion. So note the percussion note. The percussion over the heart will be variable from thin person to the obese person. So always you have to be very familiar with the pulsation note. In asthenic, in healthy, and in obese. 3 types. Examination of the healthy person is very important to note the normal note, normal sound, everything. After percussion, now your point is auscultation. Now start the auscultation. Always start the auscultation over the mitral valve area. Auscultate for the S1, S2, S3, S4, opening snap, ejection sound, mid-systolic click, diastolic murmur, systolic murmur, pancyclic murmurs, too many things. Pericardial rub, venous hum, all these should come in mind. See the mid-systolic click, if you recognize the mid-systolic click, indication of mitral valve prolapse. If you recognize the S1 is loud, it may be because of mitral stenosis, tricuspid stenosis. It may be in the fever, in tachycardia. If you noted the S2 is loud, it may be because of aortic stenosis, pulmonary stenosis, systemic hypertension, pulmonary hypertension. You are very keen observer. If you are very keen observer, you can differentiate A2 and P2. There is physiological splitting between A2 and P2. The duration between A2 and P2 is 0.03 second during expiration and 0.05 second during inspiration. That should be noted. That splitting may be paradox. E2 may come earlier, A2 may go late, as in ventricular septal defect or with the conduction disorders. You can understand the importance. Systolic murmurs in mitral regurgitation, aortic stenosis, tricuspid regurgitation, pulmonary stenosis. In ventricular septal defect, atrial septal defect. Diastolic murmurs in mitral stenosis, tricuspid stenosis, aortic regurgitation, pulmonary regurgitation, and also in atrial septal defect. Now again, you have to confirm whether it is pre-systolic, mid-systolic, late systolic, or pan-systolic. Whether it's the pre-diastolic, mid-diastolic, late diastolic, or pan-diastolic, my dear. Pan-diastolic murmur in aortic regurgitation, pan-systolic murmur in the aortic, in mitral regurgitation. Mid or late diastolic murmur in mitral stenosis, early and mid-systolic murmur in aortic stenosis. See the importance of your perception. You know the 0.3 second is there. You know the 0.5 second is there. In that time, you have to auscultate. Now, third heart sound and fourth heart sound. Normally, it is not present in the healthy person. But if the S3 is present, at which time S3 is present? After S2. Again, the first, third diastole. If S3 is present, it means there is the more blood in the left atria or right atria. Why? As in mitral regurgitation, tricuspid regurgitation. If S4 is present, again not normal, present indicates normal only in few young healthy person athletes, it may be normal present also in the pregnancy. So S4 if present indicates the left ventricular hypertrophy, any cause of left ventricular hypertrophy, and right ventricular hypertrophy can cause all this. So you now auscultate, you are auscultating your patient. The pericardial rub, very common, the lower of the left of the sternum, 4 to 6 intercostal space, very common. Pericardial rub, chest pain, confirm pericarditis, no doubt. Now these are very important point to discuss. These all points will be included when we are going for the examining the patient. In cardiovascular examination, your own knowledge, your perception, your penetrative way of the differentiation. For example, I am telling again one important thing for you regarding the murmur and sound. If these murmurs and sound are accentuated during inspiration, it is right-sided origin. Means if the S1 is loud and more during the inspiration, it is due to tricuspid stenosis. If S1 is loud, more during expiration, it is due to mitral stenosis. See. If diastolic murmur is more during the expiration due to mitral stenosis, more during inspiration, it means it is tricuspid stenosis. How much you need to concentrate? During inspiration, during expiration, during systole, during diastole. See, the opening snap is present. What is opening snap? Normally, there is not audible sound when the valve is open. There is no sound. That sound only can be recorded by the echocardiogram, but stethoscope can't measure that sound. But if the sound is present that time, it will be abnormal. In mitral stenosis and tricuspid stenosis, opening snap is present. And see, the opening snap is present after the S2. After the S2, there is isometric relaxation phase at the 0.03 second. S2 is finished 0.03 second, and then after that there is opening snap. See the gap of the 0.03, 0.04 second. 0.03 second. In between that, you have to differentiate S2 and opening snap. Similarly, ejection sound after S1, ejection sound due to aortic stenosis and pulmonary stenosis. Same after end of the isometric contraction. So only 0.05 second is there in between S1 and ejection. And that you have to differentiate, perceive, and then you can confirm as slow rising pulse, ejection sound, systolic murmur, patient comes with the chest pain, syncope, dyspnea as a case of aortic stenosis. I'll give you a few clues here. You'll be happy to know how to go for that. One point I will give you. A patient comes with dyspnea, and on examination, pulses alternates, BP, cold extremities, pulse is very weak, S1 is loud, diastolic murmur. Finding taps at the base of the lung. When they find taps at the base of the lung, please confirm pulmonary edema. Or diagnose this case. A case of the mitral stenosis. Patient after dyspnea, soft S1, no opening snap, systolic murmur. This murmur is accentuated during expiration. Confirm mitral regurgitation. Second patient. Patient comes with the chest pain, dyspnea, syncope. On examination, slow rising pulse, systolic hypertension, and then S2 is loud, systolic murmurs, ejection sound, confirm aortic stenosis. You know, the left ventricular hypertrophy is two types: concentric hypertrophy and eccentric hypertrophy. Concentric hypertrophy due to pressure overload and eccentric hypertrophy due to volume overload, my dear. This pressure overload in aortic stenosis, in systemic hypertension, and volume overload, eccentric hypertrophy in aortic regurgitation. At time is matter. I tried to make a brief note on the cardiovascular examination, my dear. Tomorrow I will talk about the ischemic heart disease, myocardial infarction, hypertension, and heart failure. A few from the allopath and some points from the Ayurveda. And tomorrow I will conclude my lecture, Cardiology in Ayurveda. Thank you to listen me. Thank you, the MUHS administrator, to give me the time for today. Thank you very much. नीचे आ जाता